C1-C2 Goins harm technique. I'm Dr. Satish Rudrappa, Director of Neuroscience and Spine Surgery at Astor Whitefield Hospital, Bangalore. This technique can be used in any atlantoaxial instability, whether it's reducible or irreducible, any condition with the basilar invagination, and even in a condition with atlantoaxial dislocation reducible variety, where there is an assimilated atlas where you have to get a better purchase. And in some cases where there is a high riding vertebral artery, you cannot do any other procedure, you can adapt the C1-C2 Goel harms technique. In this video, I'll be demonstrating a 60-year-old female who had come with a classical atlantoaxial dislocation to us with rheumatoid arthritis, where she had a classical myelopathy. Here is the patient's X-ray, which clearly shows irreducible atlantoaxial dislocation with the C1-C2 joint completely disarrayed, and you don't see the joint line at all in this patient, creating canal stenosis at that point. So MRI shows, in addition to atlantoaxial dislocation, there is a basilar invagination with a compression on the lower medulla, cervicomedullary junction with myelomalacia changes, and C1 arch is also impinging on the cord posteriorly. The axial section and sagittal section clearly shows this problem. The CT scan is always necessary in every patient for the following reasons. It will show the bony anatomy, it will show the amount of basilar invagination, is there any assimilation of the atlas, and the joint architecture as well as any destruction. In this patient, you can clearly see, in addition to significant basilar invagination, there is significant destruction of the joint, and in fact, there is a vertebral artery is almost coming to the joint level, and the right joint is involved than the left joint. So in addition to CT scan, you can do CT angio to see the vertebral artery position, but however, in our case, we always use the intraoperative Doppler, which will give much more reliable information to you than CT angio preoperatively. Whenever we operate such complex surgeries, there should be some prerequisites you have to have in your mind before entering the operation theatre. So properly see all your dynamic radiographs, including that of MRI, CT angiogram to look at the vertebral artery position when available, and always think to have intraoperative Doppler peroperatively so that you can use multiple times. And you should have all type of implants available on the table, instead of going with one single method of surgery. So you have to have atlas cable, transarticular screw set, Goel cages, and latimer screws and rods, depending on what type of the material you require. So anesthesia for all these complex cases, especially of the CV junction, should be awake intubation. You have to have a good team of neuroanesthetists who will do awake intubation, and make sure patient is conscious when you do this, and assess the power before turning the patient prone. Now both hand and leg area has to be done properly, so that you will note it down the power and it will not worsen with your positioning or anesthesia. So after turning the patient prone, once again reassess the power before you give the intravenous anesthetic to this patient, so that you can fix the head frame to them. And here you can clearly see our patient is moving all four limbs, and the anesthetist is firmly holding the neck with the tube in one hand, so that the patient's neurological assessment can be done easily. And I usually fix the patient on Sugita frame. However, you can do this procedure using Gardner's traction. And after positioning, once again, insert the needles for neuro monitoring, put it at the deltoid level and at the hamstring level and APB. These are the points where you have to look in to insert the needle for this patient. And an intraoperative, the neuro monitoring is mandatory in the present condition, and you have to take a proper motor evopotential waves before you drape the patient, so that you know that patient's neurological intact before positioning and after inducing the anesthesia. The skin incision is marked from the suboccipital region to C3 level. You need not do a big incision in the suboccipital region. It should be at the level of the foramen magnum, and up to C3 level. Give a good local anesthetic and then incise the patient with the skin to deeper parts. Maintain the hemostasis very well from the skin layer to the deeper part. And once you go into the deeper part, the fascia has to be incised. Identify the C2 spinous process. It is always better to go from inferior to superior direction. So identify the C2 lamina on one side and then go to the C1 posterior arch in the midline. And once you do the subperiastial dissection, usually bleeding is least in these patients. Expose bilaterally up to the pars level and then use the car blunt dissection, pull the soft tissue between C1-C2 up to the lateral parts. Usually when you pull that way, the the veins, which are usually there between C1-C2 on the ganglia, pops up within this loose areolar tissue rather than using the monopolar in this region. While exposing the C1 arch, it is always better to take out the soft tissues and the muscle attachment from the inferior part of the arch first, followed by the superior part. And whenever you're dissecting and using the monopolar from the midline, once you are about 1.5 centimeter, be careful superiorly because the vertebral artery comes in your view. You can use the intraoperative Doppler. You can see here, I'm using it on the superior part of the C1 arch, so that you will identify the vertebral artery easily in the both left and right side. Similar way, you can use lateral to the pars to identify the vertebral artery, and this is more useful whenever there is significant congenital anomalies in the C1-C2 region, especially in vascular invagination. The venous plexus between C1-C2 is the main hindrance of the procedure at with the Goel technique, because these venous plexus will have a lesser valve and it is a high pressure because the Batson plexus comes at that level, and dissecting the venous plexus very well and making sure not significant bleeding happens in this region is the key for the whole success of opening the C1-C2 joint. To do that, there is a loose alveolar tissue between the dura as well as the venous plexus. You identify that in the midline and then go laterally using a hook and coagulate the venous plexus on the superior part of the C2 arch and inferior part of the C1-C2 from midline to lateral, and it takes it towards the C1 ganglion. And that is the plane you have to operate for these patients so that no venous bleeding happens. So after dissecting the venous plexus at the superior part of the C2, you can go to the inferior part of the C1 arch, so that a layer of venous plexus between the dura and the ganglion of the C2 can be identified and cut slowly. And dissect it more laterally so that it will expose the C2 ganglia. At the level of the inferior surface of the C1, over the ganglion of the C2, once again, you can identify the venous plexus by subperiosteal dissection of the venous plexus from the inferior surface of the C1 arch, which is going laterally. Continue the similar way of dissection of the venous plexus on the opposite side to expose the opposite C2 ganglion and C1-C2 joint. The next step is to take out all the soft tissue on the bone so that you'll have a good surface for the bone infusion. Use the 6 mm burr with high-speed burr. Take out all the soft tissues which are still existing on C2, C1, C2 lateral, the spinous processes, and from the C1 arch, so that you can create a good bed for bone infusion. Using the monopolar, you continue taking out the soft tissues on the pars and also coagulating the venous plexus, which is there inferior to C2 ganglion, as seen in this video. You can clearly see in the video, the C2 ganglion is pushed up. We are taking out the soft tissues in and around the pars, mainly remaining on that. As you go along the pars, you will enter the capsule of the C1-C2 joint. So with this soft tissue dissection using the low current monopolar, sticking onto the pars, the capsule can be removed and you will enter the joint. Whenever you're doing this, be aware that the monopolar will not go lateral to the pars so that you not enter the vertebral artery, usually which is sitting at that point. Similarly, don't go to the medial part between the dura as well as the medial part of the pars, because the venous plexus in turn towards the anterior surface of the dura, and use of the monopolar increase the bleeding at that point. And the monopolar is the best equipment to take away the capsule, shrink the capsule so that you will see the C1-C2 joint perfectly under microscope. All these procedures should be done under microscope so that visualization of everything, including the venous plexus, can be well appreciated, and venous bleeding is least when you use the microscope. So once you see the capsule and incised, you will enter into the joint space. The soft tissue around the joint space has to be coagulated and enter into the joint. The cartilage on the joint can be removed using the sharp dissection with the 15 or 11 number blade, and then removed with pituitary forceps, so that is forceps. And taking out every bit of the cartilage is the key for the bony fusion. And once you take out the soft tissues, make sure that you not go anterior to the cord. Once again, the venous plexus, it will have more bleeding, and anything you keep there, gel foam or Surgicel, come in the view of the whole procedure when you are putting the cage. So better to avoid and maintain the clean surface so that the cage insertion becomes easier. And the curette should be used to take out every bit of the soft tissue, including when it is not coming, use the sharp knife under microscope. The cartilage can be taken out easily with the sharp knife. So you can use even the 2 mm burr to take out the surface of the C1 and C2 joints to apply, to get more raw surfaces for bony healing. So you can clearly see here, I'm taking tissue. So once you expose the C1-C2 joint, the next thing is to create the pilot hole to C1 lateral mass. Here you see I use the sharp dissector below the C1 arch, which pulls the venous plexus down. When you do the subperiosteal dissection at that point, bleeding is lesser, the ganglion is pushed down, and you will clearly see the C1 lateral mass come into the picture. And keep the dissector between the ganglion and the C1 arch so that you can create the pilot hole as shown in the picture on your left side. The direction in which we do is, it should be parallel to the arch and is about 15 to 30 degree medially, so that you'll have bicortical purchase of the screw. So that is the length. Normally, you require about 28 to 30 millimeters length. Confirm with the C-arm the direction in which you go before bicortical entry. In a classical Goel technique, we remove the C2 ganglion from the joint surface, and the ganglion is usually removed after coagulating the venous plexus on its surface. And use of the monopolar, you can cut in the middle, and to take out the inner layer of the perineurium and also the venous plexus, once again you have to use the bipolar cautery. And once the ganglion is removed, the whole space is available in such a way that you will have a total panoramic view of the whole joint, and the joint dissection, joint jacking and placement of the screw becomes very, very easy. And the key for the ganglion excision is the venous control. And at least about 1 centimeter of the ganglion, you have to cut it so that it will not come in your way of insertion of any instruments. Once you clear the cartilage from C1-C2, you can use the C1-C2 sizers, the cage sizers. You can insert into the C1-C2 joint. Start with 3.5 millimeter cage. It has to be done simultaneously both the sides, right and left side, so that you will take the picture, C-arm pictures, to identify how much the odontoid is descending down in every patient. Here you can see 3.5 mm cage I'm inserting. You have to insert in such a way that it is medially angulated rather than laterally, because the C1-C2 joint is medially angulated, and it has to cross the trialer has to cross the posterior border of the C1 arch. And sometimes there will be resistance in the beginning because of the collapse of the space. You have to use the hammer to push this inside till the anterior part of the C1-C2 joint, and then take the C-arm to double confirm the position of it. Here in this video, I have rotated the microscope. You can see the cord is on the right side. This superiorly there is a C1 lateral mass. Inferiorly is a C2 pars. So after appropriate sizing, you can insert the cage The cages will be available from the size of 3.5 millimeter, 4.5 and 5 millimeter. Here I have inserted a cage of 6 millimeter into C1-C2 after pushing the bone graft into the joint as well as into the cage. This is a sharp tooth cage, bullet cage, which is inserted into the C1-C2 space. Similar way, you have to do it in the opposite side. In this patient, you can clearly see cage is sitting properly on one side. So after inserting the cage, every time confirm with the C-arm. Here you can see we have inserted both the cages together. The pilot hole for C2 pedicle is created just below, that is about 2 mm below the joint surface of C2 and 2 to 3 millimeter from the lateral edge of the pars, directing 30-degree medial and superior. And always confirm the angulation using the C-arm or navigation when used. The track usually accommodates a self-drilling screw of 20 millimeter. Here you can see I am using a 2 millimeter burr to direct it towards the pedicle. And once you create the palate hole, wax it so that it will not bleed. The pars screw pilot hole is created based on the angulation of the pars with respect to C2 lamina. Usually, it will be in an angulation of 35 to 45 degrees with narrow C1-2 opening. To achieve the track angle of 35 degree might be difficult, and to negate this, we usually use an additional small paramedian incision in line with the pars around T1 and T2 level, so that using the tunnel technique with guide with the sheath, we can create this trajectory. The starting point of the trajectory will be done using the 2 mm burr, 2 mm above the C2-3 joint and lateral from the spinal canal using the C-arm control. Once created, a drill guide is used to enlarge the track to accommodate 3.5 centimeter, 3.5 millimeter threaded multi-axial screw. So in this video, you can clearly see I'm putting the goel plate after making the pilot hole at C1 and C2 level. Reorient yourself. I have rotated the video accordingly so that I've been alignment with the screw positioning with respect to C1 lateral mass and C2. So the plate should be in such a way that it will buttress the C1-C2 joint, and it should compress the cage in such a way that the screws will hold the plate and the joint becomes stabilized perfectly. In Harm's technique, unlike Goel's technique, C2 ganglion is not resected, and we use a 3.5 millimeter C1 lateral mass screw and C2 pars screws, and are connected with the appropriate length rod to achieve the stability at C1-C2 joint. In Harm's technique, because we have preserved C2 ganglion and it should not be irritated with the screw of the C1, a gel foam has to be inserted between the C2 ganglion and the screw threads. A long pencil graft which are taken from the iliac crest can then be placed between C1, C2 and around the rod and screws and plates, so that you will have a solid fusion in Harm's Goel technique. Take a final shoot with the C-arm to see all the position of the cage and screws, and the wound will be closed in layers to make sure that there is no clot or any formation in these patients. And close the wound properly, take a final MEP to confirm neurological integrity. In conclusion, C1-2 Goel Harm's technique are versatile procedures. Can be used in various C1-2 pathologies. C1-2 joint anatomy, venous plexus dissection, and C2 ganglion dissection is the key to success. With C2 ganglion excision and jacking of the C1-2 joint space, reduction of basilar invagination of any grade can easily be achieved. A small modification of the plate and locking screws will help in better stability in the future.